cover the musculoskeletal exam, and I'm going to start with the upper extremities. I'm going to start with the shoulder, we're going to move to the elbow, and then we're going to look at the hand. The MSK exam is important, particularly to look, it is really important to look for symmetry and examine the extremities at the same time as much as you can. Not only does it save time, but it allows you to compare side to side. One thing to note, the shoulder is a very, very large joint and can hold a lot of fluid and blood. So you can examine a shoulder and oftentimes find nothing. Nonetheless, we're going to start with inspection first. And I'm just inspecting the shoulder, looking for any abnormalities. I'm going to compare side to side, noticing for how the shoulders are aligned, where they sit, how they, what the musculature is. Is there atrophy of the muscle or is it normal? So that's pretty much inspection. I'm then going to move to palpation. Now the shoulder joint is a fairly, as I said, a large joint. And oftentimes, if the patient has tenderness or arthritis in the joint, you'll be able to note that on palpation. And the way you do that is that you're going to palpate the glenohumeral joint starting midline and moving on both sides. And so I usually start about right here. And I'm using a good amount of pressure, right? My nail beds are turning white. I'm not lightly palpating here. And I'm going to palpate along the glenohumeral joint. And I notice there's no tenderness. Sometimes if someone has shoulder pain and it's coming from a rotator cuff or an impingement problem, you can tell that there will be tenderness along the acromioclavicular joint as well. And there is none. I'm going to do the same thing for the left shoulder. I'm just palpating along the glenohumeral joint, using a good amount of pressure. And if there's some tenderness, patient will certainly tell me. And again, I'm checking the AC joint, the acromioclavicular joint, palpating across to notice if there's any tenderness there. So the next thing that you're going to do is look at range of motion. The best way to examine range of motion is to examine the patient going through the motions in both arms at the same time. So you're examining the movement of the shoulders at the same time. The easiest way for us, that I do this, is to have the patient mimic what I do. And so I'll tell the patient, so I'm going to just tell you what to do, and you just I'll show you what I'm doing, and then you just copy me. Okay? So I'd first like you to do is take your arms on your side and lift them above your head. Good. And go ahead and return back. Good. So I've checked for abduction and adduction in both arms, both shoulders at the same time. The next thing I'm going to do is examine for rotation. And so what I'd like you to do is take your hands like this and move outwards. Great. So that's looking for external, that's externally rotating the shoulder joint. And then I'm going to have you just rotate your arms in and go to the back of the lower back of your spine. Perfect. So that checked for internal rotation as well. And then I'm going to check for flexion, forward flexion. So if you'll just do what I do, take your arms, move them forward as high as you can above your head, and then move back down, and then behind you as much as you can. Great. So we tested for forward flexion, backward flexion, abduction, adduction, internal rotation, and external rotation. So that was all active range of motion. What you're going to do next takes a little bit more time, and this is testing for passive range of motion. This is always a challenging test because oftentimes patients truly won't let you do all of the work for them, but you're basically testing the same areas, but you're doing all the work and you're not having the patient exert themselves at all. And so I'll start here, and I'll have the patient, and so what I tell the patient is, you just let me do all the work, you relax, and I'm going to move the shoulder joint. So I'm doing all the movement, I'm having the patient, I'm abducting the patient's arm for them all the way up, I'm adducting in, going internally, checking externally, and I'm going to have the patient flex forward, upwards, and backwards. And I'm going to do the same thing for the opposite shoulder. Next, we're going to look at the elbow. And again, as I said, normally we like to inspect the elbows first, and you're going to inspect both elbows on both sides. And what am I looking for? I'm looking for redness. I'm looking for abnormalities or deformities. I'm looking for nodules, which could signify rheumatological diseases. The next thing I'm going to do after inspection is palpation. And I'm going to palpate sort of in the anterior cubital fossa, but I'm also palpating all along the joint externally as well. Okay? And again, I'm noticing, feeling for any effusions, which is basically swelling or fluid accumulations, feeling for warmth. Oftentimes, if a joint is infected, it'll be red or hot. And again, chesting for any abnormalities. Next, we're going to do active and passive range of motion, just like I did on the shoulder. So let's start with passive range of motion here. Remember, so you can go ahead and, again, the passive range of motion means that the physician does the majority of does all of the work. The patient is just relaxed. So I'm first going to have the patient flex their arm, extend out. The next, you're going to have the patient supinate, noticing any, noting for any tenderness, and you're going to do the same thing for the other. And the next thing we're going to check is for active range of motion. So I'm going to have you make a muscle for me, move in, extend out, turn your wrist inwards, good, and turn it the other way. So we covered very quickly flexion, extension, supination, and pronation. We're going to look at the hands. Inspection of the hands can actually tell you a lot of information, right? We've already looked at the nails, and so when I'm looking at the hands, I'm looking at different areas. I'm taking an opportunity to look at the wrist, noting any abnormalities, looking at the knuckles to see if anything is particularly enlarged or red, and then I'm looking at the metacarpophalangeal joints. So I'm looking at the PIPs and the DIPs here. And I'm looking for any Heberden's nodes or Bouchard's nodes, which could indicate that the patient has arthritis. And doing the same thing for the opposite hand, and there are no abnormalities. And again, the next step is to test for active and passive range of motion. And so the hand, there's a couple of more steps that you've got to cover. So the first thing I would do is just have the patient make a fist. Great. Noting for any pain or difficulty in doing that, and have the patient open their hand up. The next thing you're going to do is test for the strength of their fingers. So what I'm going to do is have you keep your hands apart, and I'm going to try to pull your fingers together. Good. Good. And you're going to do the same thing here. And you're going to do that on both sides. And then we're going to test for opposition as well. So I'm going to have you just take your finger, and I want you to try to touch your thumb to your finger. Good. You're stronger than I am. Good. And do the same thing, pull back. Good. Check. And then you'll check for passive range of motion as well. So I have the patient I sort of basically move the patient's hand according to what we can do here, what's comfortable for the patient. And I'm just sort of seeing how their hands move. I'm pulling out the thumb away from the finger, moving them together, right? Checking the fingers, moving them apart, moving them together. But as you note, common sense dictates that if the patient can actively move their fingers and it be non-tender, they can passively do that too. So the next thing we're going to do is look at the spine. I'm going to start at the cervical spine, right? So the first thing I'm doing is I'm just going to inspect. I'm again inspecting for any abnormalities, any asymmetry between the shoulder and the neck, and then I'm going to palpate. And as I'm palpating, I'm really palpating, checking for any abnormalities, any muscle tension or tightness, and any tenderness to palpation. The next thing I'm going to do is again go back to range of motion. So what I'll have the patient do is turn towards me, and what I'm going to have you do is we're going to check your range of motion of your neck. And so what I'm going to have you do first is take your chin and touch it to your chest if you can. Good. And again, I'm noting the patient's ability to do that and the presence of pain if they do it. Now I want you to take your head and just move it side to side. Good. If the patient had marked tenderness, they would probably be able to move their head about this much, and then that might cause some tenderness. The next thing I'm going to do is have you tilt your head on either side. Great. And I want you to then move your head back. Great. So I covered flexion, extension, rotation, and abduction and adduction. Next, what I'm going to do is inspect the lumbar spine. And I'm doing the same thing, noting for any abnormalities, noting for any scoliosis or kyphosis, and everything appears normal here. So on inspection, everything is normal. The next thing that I do is I palpate. And what I'm doing here is I actually start around thoracic. Since we've covered the cervical, I start around the thoracic and I palpate with some amount of pressure right on the spinous process. And what I'm doing here is checking for spinous process tenderness. If someone has spinous process tenderness, it could be an indication that they have significant amount of bone pain, which could be associated with many serious illnesses. The next thing I'm going to do is have the patient demonstrate their range of motion for me. And so usually the best way to do this is have the patient face you again. And what I want you to do is just take your fingers and touch your toes for me and stop if it's bothering you or painful, okay? And stand back up. The next thing I want you to do is lean back as much as you can without hurting yourself, okay? So we got flexion and extension. And then the next thing I want you to do is sort of bend as much as you can without having any pain on side to side. Great. Lastly, standing straight, I just want you to try to rotate your spine as much as you can. Great. And do it the other opposite end. Great. And basically what you're noting for is the ability to actually do it and any tenderness with that kind of motion.